And other than that, yes, Bob, we'll have you go ahead and start. And as folks have questions, please feel free to put them either in the Q&A or the chat. And we can get to them either as they come up or at the end. But otherwise, Bob, I will turn it over to you.
Okay. Like this. Another button. Make sure you can see the whole screen. Are you seeing presenter view? This must be. There we go. Okay. So I'm a professor of psychiatry at the UW, and I run the Partnership Access Line program. I don't have anything to disclose. So the main thing I want to be sure I talk about right at the beginning here is our SAFES program. You know, everybody loves acronyms. We had to come up with one for this program. SAFES is what we came up with. Stands for Supporting Adolescents and Families Experiencing Suicidality. What does this mean? So in a partnership with the Washington State Department of Health, we got a federal grant. So with HRSA funding, there's money for us to do this collaboration with Frontier Behavioral Health that is based on a program developed at Seattle Children's that we developed for addressing suicidal patients presenting to the emergency room that were essentially frequent flyers that kind of kept coming in and leaving and were suicidal and coming back and not getting the kind of support care they needed, and they kept coming back and kept coming back and couldn't get out of the cycle of suicidality, repeat, come back to ER, suicidality, come back to the ER, repeat. And what developed is a program of 4 sessions of suicide-specific psychotherapy that was rapid access, targeted at both the youth and a caregiver. So it's sort of a joint program where both the caregiver and the patient gets simultaneous, like the caregiver and patient both are getting their sessions at the same time, talking, you know, the caregiver talking about what's going on as they're dealing with the suicidal kid in their household. How are they managing things? What kind of supports do they need? As well as talking with the kid, and then kind of jointly together, okay, what sort of care planning approach is going to work to keep them safe and move things forward. So it's supporting both the caregiver and their adolescent with the suicidality crisis and the crisis supports, and it found that approach had been pretty successful. So this was an idea of bringing this to a new community in Eastern Washington, and then linking it and access with the PAL program. Oops. How about if I use this? Okay, there we go. Now it works. On the right is a map of, obviously, state of Washington, and the colors are the two, if you aren't familiar, accountable communities of health, how the state has organized service regions. And these two accountable communities of health are officially our target regions for the program. And the SAFES program can be delivered entirely via televideo. So a family doesn't actually have to go in person to Frontier. They can go in person for one session for all sessions, or they can have all services via televideo. So someone in Okanagan, Chelan, Douglas, and Grant, they could just all services via televideo. They just need to live in one of these counties, be age 12 to 18, can be any insurance, can be Medicaid, could be a private insurance, so they could have no insurance. And they have to have a primary care provider, like yourself, with active concerns about suicidality, but it's not like so severe that they have to go to an ER right at this moment. That they need to be considered for admission. So it's a service that's rapidly accessed, but it's not going to be about, oh, they're seeing you today. And they can have a counselor, but typically that would be the counselor. It's beyond what the counselor can support. And the process to refer somebody in is you having a concern and calling PAL, just as you would for any other consult, but you say, I got an adolescent with suicidality. I think they need more support, or I want to make a SAFES referral. So you could call us for a regular consult, and then we can just suggest it, or you could call PAL and say, I don't want to do a full consult. I just want to refer this kid in the SAFES program. And then we can kind of cut to the chase and learn just enough information about the adolescent in order to tell the SAFES team, what they're getting. A SAFES referral, we do need to find out the family's, the parent's name, family phone number, and we do need you to tell the family that somebody's going to be calling them. It's a failed referral if the family gets a phone call and they didn't expect a call from somebody at Frontier, says, I'm calling from the SAFES program. They'll say, like, who the heck is this? And then hang up the phone. So, you as a provider have to tell the family about this, what it is, and that somebody Frontier in the SAFES program would be calling them. Is that something that they would like? And then that warm handoff connection can work. It's again, rapid access. So if we were at a point where the SAFES program had no appointments available within 2 weeks, we would say the program's full. Right now, there's actually 6 slots available in the program, so you could get immediately in the door, and we can tell you all that over the phone. So anyway, you can call the number or email the SAFES program, safes@seattlechildrens.org. I'll can pause if anybody had any questions about that right now.
We have one question so far, Bob.
Yeah.
Are these the moderate risk kids on a Columbia suicide screen?
Yes, they can be a moderate risk on a Columbia suicide screen. So essentially, you're concerned. They don't actually have to be. The idea is they don't have to be admitted today. They're not. I'm going to kill myself today. But you're pretty concerned. They have some significant suicidality, and it's more than, either you have a therapist and it's more than what that therapist can handle, or they need to get to a therapist and it's going to be a month until they can see a therapist. It's like, there's some significant suicidality. We need to get some support now. So absolutely appropriate. So it's really a great resource. We would love it to be used a lot more right away. We're in the season where kids are having a hard time, and we would love to see this utilized as much as possible. And then the other resource that we've supported, again, this is state funding. This is the Washington State, and the Healthcare Authority is paying for this. The Washington State Mental Health Referral Service for Children and Teens. This is a parent call-in line. So it's separate than what PAL is, which is a call-in line for you as providers. This is if a parent says, I want to find a therapist, and they don't know how to do that, and are struggling to do that in some way, the parents can call the number on the bottom of the screen here, 833-303-5437. Or frankly, it's really easy to Google and find that number. You just type in Washington Mental Health Referral, and this will be like number 1 on the list. It'll pop up. And the service is paid for by the state to help any parent, regardless of insurance. So actually, like 70% of the requests are from people with commercial insurance in the state. And the team will call around for checking out availability. And this is not instant because of the fact that they call around for availability before saying, okay, we found two people or two practices that have this kind of availability, call them right now. So it takes you have to tell the families that, you call the service, it's going to take a few weeks for them to give you some names. There are, is a hospital program. There's, a translator service that has every language available. We do have a Spanish speaking referral specialist on the team, so that's gone over particularly well. So just be sure you tell families about this. We'd love it to be used more in general on the eastern side of the state than it has been. So the more you promote this number, the more we would appreciate that as well. Any questions about this before I go on?
So we have one question or
Yeah.
comment. It just says, I use this referral service all the time. I have a smart phrase and epic for the families. They love having one number to call to start the process. Thank you for this.
It's an easy thing to recommend to the family. Whether they'll use it, there are drop-offs. Anytime you recommend a referral for a family, just to kind of be aware, and research has shown this. If you recommend mental health therapy, even if you tell them this person is available right now, please call them. How often families will actually call? Yeah. There's a huge drop off. A lot of times you have to go to that well multiple times before families will follow through. And when we do our 2-week follow-ups with families after they have been really hunting and looking for therapy, it's a lot of times they still don't follow through. And then they'll tell us things like, oh, we've kind of changed our mind, and oh, we decided this, or they offered an appointment at 2 o'clock, and we decided, oh, we could only do things at 3. And so there's all these things that come up and that are in the way in reality, unfortunately. And then I've got some content about managing suicidality in your office. I don't know how much time y'all have, but I have some thoughts about suicidal patients in your office that I'll spend like 20 minutes going over. So just have a basic approach for when you have somebody suicidal in your office at the time. And I am going to mention about the risk scales as well, like you have mentioned. First of all, self-harm is separate from suicidality. There's a lot of self-harm out there. 10% of adolescents will say they do self-harm at some point or another, and hospitalized. In my realm, it's way more common. Sort of depends on where you look. And we have this term non-suicidal self-injury, so it's not always suicidal in intent self-harm. And there's a range of things. Sometimes people will do things to deny themselves a necessity. Sometimes they will hit themselves or punch themselves or pull their own hair, versus cutting themselves or burning themselves or taking an overdose or putting hands to their own throat. And then obviously high lethality is self-harm. It's like hanging in firearms. That's always equal a suicide attempt. Reasons for self-harm. Usually if you ask somebody, well, why you do it? The last time you did self-harm, cut yourself, why did you do it? You're usually going to hear some variation of a statement that they had an unbearable feeling, their state of mind, and they just wanted it to stop. They wanted to distract themselves. Sometimes you will hear a patient tell you that they felt they deserved to be punished, or that they wanted to show somebody else how they felt. I've had a number of patients over the years actually say use a blade to write a word onto their arm, write somebody's name onto their arm so they can basically show somebody, look at what you made me do, that kind of thing. Somebody who's been heavily traumatized might self-harm when they're dissociating, and they say that they do the self-harm so that they can feel real again, or in order to feel something again. And then obviously sometimes self-harm is with intent to die. Excuse me. Somebody who's doing this repeatedly, more than just once, like half the people who self-harm only do it one time, but some do it repeatedly, obviously, and those are the ones you're more concerned about. And it's, frequent intense negative emotions, poor coping skills, psychiatric illness, kind of makes sense, suicidal thoughts, history of abuse and neglect, and difficulty experiencing emotions. So um, in general, when somebody's having self-harm, the ideal thing is to have the one-on-one discussion, and have a discussion about, say, tell me about the last time you hurt yourself. What was going on at that time? What did you think was happened from that? Did that help you in the way you thought it would? And then how long did that help you? It's an opportunity when you ask them how long that helped you, because somebody who's repeatedly self-harming is going to be able to tell you, yeah, I get it, I get relief, but honestly, it lasts for an hour, 15 minutes, an hour, maybe at the longest, I reset my thoughts or feelings for a day. But it's not going to, change their outlook on the world for weeks. You could also ask a question like, what didn't you like about it? So that if they tell you the reasons for they don't like it, that's an opportunity for motivational interviewing. Somebody who is repeatedly self-harming, this is one of the therapist tricks I learned many years ago, that you can describe the self-harm as an overwhelming sensory experience. When you do, say, cutting, it distracts you, it focuses your attention on this overwhelming sensory experience, and then you can't think of anything else other than that for a period of time. So you'd say, if you had another kind of overwhelming sensory experience that achieved really the same result but didn't injure your body, would you want to try that? And sometimes people don't want to try that because they really like the idea of, I've cut myself, just the idea I'm cutting myself, but others would. And you can do replacement sensory experiences, like holding an atomic fireball candy in your mouth while it dissolves, and that's very distracting. People can carry one around in individually wrapped atomic fireballs, or take a hot bath, or apply lotion over your entire body, or snap a rubber band around your wrist, or hold an ice cube while it completely melts all the way in your hand, or listening to hard metal music, or watching a whole movie or something like that. So there are other things that can lead you to be in a different mood state by the time you finish the other sensory experience. And of course, getting them to a therapist. If anybody's repeatedly self-harming, it's an obvious need to refer to counseling. And the treatment for self-harm is psychotherapy. uh, um, and it's not medication, unfortunately. Their medicines don't really work for that. Suicidality, it's a little scary. The surveys asking adolescents how often they think about killing themselves or have made suicide attempts. During the pandemic, the data went up of how often this happens. Most of you dealing with the pandemic saw this in your practices as well, but the national surveys support that. So adolescents around the country in 2021, early, that was actually just beginning of pandemic time, said 22% seriously considered committing suicide, 18% made a plan, 10% self-reported, mind you, self-reported that they had attempted suicide, and 3% so severely they needed treatment. Thankfully, most suicidal thoughts don't lead to suicide attempts. There's about one death for every 100 attempts, and that data is really hard to come by because most attempts are not reported. So that's a pretty broad estimate. Boys, unfortunately, choose more fatal means than girls do, and so there's more boys that die from suicide than girls. There's more attempts amongst girls, but boys have more fatalities from suicide. It's about the second leading cause of death because most kids don't die from disease. It's not common, but they don't die very often. There are things that put kids at risk from suicide that you can't change so easily. Having been abused, being a boy, having made other attempts, have a family history of suicide, like a parent who died of suicide, you can't change that history. Struggling with your gender identity, you can change the struggle, but you can't change gender identity, for instance. Or there are things that you can modify, like if you have a mental health disorder, you can treat that. If you have substance abuse problems, you can treat that. If you're having problems in school, you can address that. Stressful life events, you can coach through that. You can address bullying, you can address social isolation. And how do kids die? This kind of clues you into this, what sets my antenna up. If somebody tells me about their plans of how they would kill themselves. So if somebody's plan involves hanging or a firearm, I'm always more concerned, because the vast majorities of death by suicide are firearms and hanging. Overdoses are about 5-6% of all death by suicide amongst youth, and falls from a great height, about 3%. Everything else is less common than 3%. So cutting, although a common self-harm technique, is extremely unusual as a cause of death from suicide. And screening for suicidality, the general approach is broad questions, and then when you start getting positive, you get more specific. That's how the rating scales are set up too. So so if you're just doing this on the fly, you can ask a question in general. Have you ever wished you were dead? Have you ever thought about killing yourself? Somebody says no to those questions, you're done. Wipe your hands, move on to the next thing. If somebody says, yeah, why are you asking that? Say, well, have you thought about killing yourself recently? Do you have any plans now for how you'd kill yourself? Do you have access to those means? Have you tried to kill yourself? Asking those questions on a regular basis flows a little more naturally as you practice. And then when you get a yes, a lot of times people get anxious about that. Just know that being able to reflect that, wow, you've come close to killing yourself, and make an honest statement, reflecting statement like that, does something positive. And acknowledging how the adolescent feels demonstrates your understanding. And then you can follow that up with things like, I want to see you again. I want to do something about it. I want to, do steps to try to connect you into care, all positives to help keep them safe. So the questionnaires, yes, there's depression rating scales. Some of them have, PHQ has a self-harm urge on there. Collateral information from a caregiver, sometimes particularly helpful, because not every adolescent is exactly truthful. The questionnaires on suicidality, questionnaires to an adolescent on suicidality, like things that an adolescent would fill out on their own suicidal thoughts, have been shown to be overly sensitive, lack predictive value. It's really interview questions that are more useful, which is why the Columbia and the Ask are designed as interview questions. So this is the Columbia, or a version of the Columbia, and you can see it set up with some broad screening questions at the beginning, and then more specific questions after that if you get positives. And they're questions you ask of the patient. So to the ASQ, or Ask, which is similar in format, just slightly different worded questions to ask of the patient, rather than, again, a patient questionnaire that they fill out. And then ultimately, if you are assessing somebody's suicidal risks, what's the secret sauce of knowing if somebody's at high risk? It's learning the details of their situation. A psychiatrist isn't any better at predicting risk than anybody else. The only thing that a psychiatrist or a psychologist or or ED evaluator does is keep asking questions about the situation and projecting by asking the questions that they in fact want to know the answers to those questions. And then once you hear the details of the situation, you would apply a reasonable person standard to saying, how risky does this sound? The adolescent who says, yeah, I was seriously considering committing suicide a few days ago, but then I decided that it was against my religion, and my girlfriend would be so mad at me, so I decided I wasn't going to do it. And all this other stuff is stressful, but then I talked to this other person, and so it's, I'm not thinking about it so much anymore. I still feeling really down. I get those thoughts occasionally. Totally different than getting those thoughts, every night. The last time I brought it up to my dad, he yelled at me and took everything away, so I don't have anything left in my room. I tried reaching out to somebody else, and they my one friend is left, and they told me to F off. I've got my uncle's gun. I hid it. Nobody knows where it is. As soon as I decide I want to do it, I'm going to do it. Completely different risk scenarios. But as soon as you hear those details, a reasonable person knows one is very high risk, one is not. So, if somebody's at moderate or high risk suicide, immediate mental health options are, consult with somebody else, consider sending to an ER, consider hospitalization. And by the way, hospitalizations overall aren't all that effective at reducing long-term suicide risks. They do keep you safe while you're there. But hospitalization alone doesn't really solve everything. It's the counseling that comes after that tends to be more effective, frankly. There's sometimes people will focus in on the no suicide contract. Well, I sent them home because I had them sign a no suicide contract. Please don't just kind of hyper rely on that. Not that it's terrible to have said that, but please do other things too. Because just saying that's not what lawyers call a contract. Setting up here's what the safety planning is that we are doing. Here's how we've made a plan to be safe. Not, I promise I'm going to be safe. But I just told you also that I've got the gun that's hidden, and I'm going to use it as soon as I want to, and there's nobody there for me. That's not a safety plan. So, what might a safety or crisis plan be? What might trigger the suicidal thoughts? How might somebody else know you need help? What could people do if you need help? What would the parent do if they, could they, encourage you call Aunt Sue, or talk to a friend, or talk to them, or watch a movie together, or whatever? What makes sense? Is there a mental health provider? What's their number to call? Can we safety proof the house? Can we get rid of the firearms temporarily? Can we make sure there's somebody around so that you can't just simply hang yourself when everybody goes on vacation for a week? Can we get rid of the giant bottle of tricyclics that's been sitting in the cupboard for a year and everybody forgot was there? All that sort of stuff. Know the suicide hotlines to call. If somebody's lower risk, just validating, letting them know you're there and you want to see them again alone reduces suicide risk. There was an interesting research study done by Henry Ford System where they did this thing called a caring letter after an ER visit and did a randomized trial. Somebody showed up for an ER, a whole group of patients, so they didn't need to be hospitalized, and they said, some of them got a standard follow-up letter, and some of them got a letter that just was it was a single page form letter that said, we were thinking about you and hope you got connected into care. Just a little bit more caring form letter. And they found that those got the caring form letter after the ER visit had a very significant reduction in repeat ER visits for suicidality, and within health system, other presentations for suicide presentations. So, had a pretty big impact. So just saying you care and you want to see them again, or are there for them, is an intervention. When there is a risk of suicide and the adolescent says, "Oh, I don't want you to tell anybody," you have to tell people around safety. I need to have somebody help keep you safe. I don't need to tell everybody everything you've told me, but I just need them to know that there are times when you may need help about keeping yourself safe, and how can we do that. And there's adequate supervision. Meds don't work for suicidality, really. And people will ask for a pill to resolve the suicidal ideation, but that's not the treatment of choice. Meds can sometimes help with depression, but they take a month or longer when they do help. And there's paradoxically, sometimes SSRIs can increase suicidal thoughts in the short term. I think really by a method of where sometimes SSRIs cause irritability and agitation, and then you add that into already being suicidal or anxious, and then it's, the increased suicidal thoughts can start to make sense for those patients. It's really all about safety planning and addressing access to suicidal needs. So back to SAFES, just a reminder, give us a call about any kids that you're seeing with significant suicidality, and we can coach through the process of making a SAFES referral. And if we're doing that, you have to be sure you're talking to the family too about the SAFES referral, because we can't just cold call the families. We've figured out that doesn't go real well. The families don't respond real well. They have to call and say, "I'm calling on behalf of Dr. So-and-so to try to get you connected into some rapid access crisis care." And we can kind of re-explain it all at the time, but they got to know we're calling. So anyway, questions? I ran through everything.
Thanks, Bob. We do have another question in the Q&A. It's from a little bit earlier, but it says, to clarify, for self-harm, is the psychotherapy recommended still CBT, or is DBT preferred?
Oh, good question. So for psychotherapy for self-harm, for repeated, recurrent, kind of long-term self-harm, there's a particular kind of origin of recurrent self-harm for which DBT was designed for, and that was for patients with borderline personality disorder. Now, adolescents, we try not to say that they have a personality disorder, because adolescents have personalities that do change and evolve, but there's clearly adolescents who have that range of problem, and typically those adolescents with who have the borderline personality traits, not just recurrent self-harm, they most often have a history of very significant neglect or abuse in their childhood, and have a chronic hard time, and the recurrent self-harm is one symptom of it. And for them, DBT can be really useful. DBT is not always available. It's often hard to get into, but it's worth advocating for somebody who has that kind of chronic personality problem and recurrent self-harm. Just recurrent self-harm, it may or may not be appropriate to get them in, and depending on your DBT program, they may or may not bring them in. It sort of depends on the dynamic of the group. If there's a lot of, say, wild and woolly borderline personality disorder patients in there, and sort of an urban mild sort of recurrent cutter who introduces themselves into that group, it may be a very poor fit. So in general, some recurrent self-harm might be just most appropriate for CBT. That's usually easier to access and a good place to start. The process to get into DBT is often a longer road that you have to fight for in most communities. Is there anybody has feedback about what it's like to access DBT in Spokane at the moment? Because I just don't have that feedback for you right now. The referral team might. But. I mean, the skills, I'm a fan of DBT. One of the things I did in training was I was a DBT therapist in my adult training. It's good skills, good life skills that everybody can learn of emotion regulation, distress tolerance, and things like that. So I'm a fan of it. It's just it can be hard to access.
We do have a comment that says the RISE program at Holy Family may emulate that in a way. They have a group therapy component.
Mhm. There are there's also a possibility of doing group therapy with the parents or caregivers of kids who are doing recurrent self-harm. That not every program does, but sometimes is necessary to impact change too. So lots of different approaches available out there.
I saw in the chat that someone had a few questions. Kim, if you want to come off mute, you're more than welcome to do so.
Stop share so that I can see faces. There we go.
Hi, this is Kim. I'm in Spokane, and thank you, Dr. Hilt, for doing this. I just have a couple questions. You had mentioned that you have 6 spots left in the SAFES program. Is
Currently,
there?
yeah, it's a 4-week program, and so the things are turning over. There's 8 spots total available at any one point in time. So there's only 2 right now.
Okay, that was my question. Like, what's your patient load and the turnover? Perfect.
Mm-hmm.
Okay. And then oh dang it, I lost my second question. Oh, I'll pop back on if I think about it. Thank you.
Mm-hmm. And we would consider the program full if somebody can't get in within 2 weeks, and we would give you different coaching if we heard, we haven't had that come up yet. We've always heard about these kids who are suicidal at the PAL line. And if for some reason in the future it ever happened that the program was full, it hasn't come up yet. We would still provide good coaching, I'm sure. But right now we haven't come close to being full. So for the near future, I would anticipate us always having a spot for you.
I have another question. It says unrelated, but related to mood disorders. What do you at Seattle Children's think about parents wanting to use magnesium for mood and sleep in their depressed and anxious teens?
It's sort of I always approach those questions in the first do no harm approach. So as long as they're not giving the kids so much magnesium that they're having diarrhea or some sort of toxicity from it, it's like, oh, okay. But extremely unlikely that it's going to lead to dramatic improvement. There's if they're going to do supplements, giving a lot of fish oil. Of course, kids don't want to take fish oil. there was a lot of excitement about vitamin D because we're in the Northwest and we don't get a lot of sun, and it was associated with our low vitamin D levels and our depression levels. And oh my gosh, everybody's got to give vitamin D. And it took a long time to figure out, it's like, by the way, when you give vitamin D, it doesn't really improve anything. So still a lot of people give vitamin D and think, oh yes, that's going to work. And it doesn't really. I wish I could endorse that it would help. But as long as you aren't doing harm.
Yeah, I think that I think it's the latest supplement that's seeing the craze right now. I mean, I've been getting a lot of questions about magnesium.
Yeah. Yeah, and we actually, one of my fellows just had somebody discontinue an SSRI that was actually working because the parents said, "Oh, we read something that St. John's wort is the way to go," and the adolescent was really mad because they liked how the SSRI was working, and parents wanted to give St. John's wort.
Hey, Dr. Hill, it's Kim again. You reminded me of my question. If you if you have a kiddo that's on an SSRI and they have some of that increased suicidality on them, are you is that a movement towards taking them off the SSRI or getting them therapy?
Well, it's a good question. So a couple parts. So, if they get increased suicide, so, I'll step back. So part of the decision to even put them on an SSRI very likely is because either the depression's getting worse or they're having some suicidality. So there's always that kind of, is it a chicken or egg question? I had a patient the other day who the parent blamed the med for suicidality, but actually at the time the med was prescribed, it was being prescribed because there was depression that was getting so bad there was suicidality, and they kind of forgot that was the reason why it was prescribed in the first place. They just sort of blanked that out. So there was no change. It was just they were blaming the medicine. So is it in fact new? Because there is a phenomenon. It does happen sometimes that there could be new or increasing suicidality from the SSRI. And if that happens, it's, is it, it may have been that it would have happened anyway, that maybe the depression was getting worse or the social situation was getting worse and it was completely irrelevant to the SSRI, or it could have been the SSRI. Better part of valor is usually you'd have to stop it. If you think it's an SSRI side effect, or the assessment is this is likely an SSRI side effect, I don't taper. I'll just stop it. Because if you drag it out, take forever, and I don't immediately switch to another one. I'd say, okay, if we think this might be or is an SSRI side effect, we'll stop the SSRI, and then this should go away in 2-3 weeks. If we're 3 weeks from now and we're still having just as much suicidality and it's 3 weeks since the medicine, I guess it wasn't the medicine. And we will have learned that, because if you went and switched from one SSRI to another SSRI, and you're still having the suicidality, and you say, well, that one's doing it too, whereas maybe it's just their new baseline. So all of this gets a little tricky to interpret. Sometimes you just have to make the call, take away the medicine, and wait and prove, okay, is it the medicine or not? To make this what's hard to interpret cleaner to interpret.
And so you would, oh, sorry, you would stop at any dose, just take it away at any level?
Yes, because typically, if this is an SSRI side effect, it's happening in the first couple of months of use. This isn't something that's, oh, they've been on it for a year and now it's SSRI suicidality. This is a first few months of use thing.
Okay, that's helpful. I had a kiddo that had been on some Prozac for anxiety for a long time and then started getting some suicidal symptoms, and I did not take her off. She had some other things that were going on that was maybe driving it, and we just check in weekly with updates and kind of implemented a few other things for her, and she's doing fine. So
yeah, it's when it happens, it's a first few months of use thing as a side effect of the medicine, not suddenly appearing years later.
okay, thank you.
Yeah.
I will say we're just at about 10 to 8.
Oh, wow. Yeah.
Yeah, this has been really wonderful. If any folks have last minute questions, feel free to come off mute if you are able to do so, or type it into the Q&A or chat. We can sort of wait another minute here while I share one quick announcement. And if all the questions have been answered, then we can enjoy the rest of our Thursdays. Again, thank you to Dr. Hilt for putting this presentation together. Very much appreciate taking the time out of everybody's mornings to talk about this very important program and process.
Fun topic of suicidality.
We did record this, so I can send out a link to the recording to all participants in case there were things you wanted to go back through and look at. Or if you would like to share with others in your practice. I will also share, there is a SAFES flyer that has gone out a couple of times from us here at the chapter through developments and in emails. I will send that flyer along as well. If folks have an interest in wanting those flyers printed so you can hang them in various places for others to see, please let me know. I will put my email, well, you'll have my email because I'll email you. Let me know. We have some printed that we can send to folks. And then last but not least, just a small plug for those of you who are interested in participating in the upcoming legislative session, either through testimony or signing on pro or con to bills. We can, that's coming up in February. So visit our website, wcaap.org, to learn more about our advocacy efforts and how you can be involved. Some of the things we're hoping to work on this year are directly centered around increasing access to behavioral health care for children and teens, since we know that is still such a huge pressing issue for our families and the kiddos here in Washington State and beyond. Just one more question, just comment. Thank you. Very grateful for your program. And so without further ado, I haven't seen any more questions come through. I will give a minute. Did anybody want to come off mute and say anything or have a question?